respected chairpersons, chief guests, special guests, honorable speakers, and panel of experts, learned audience, good afternoon to you all. With the permission of Chair, I am Dr. Salma, Registered Fertility Care and IVF Center of Dhaka Medical College Hospital, and member of Fertility and Sterility Society of Bangladesh. Welcome you all to today's webinar on Management of Infertility, Country Perspective. World Infertility Awareness Month is celebrated every June to increase regarding issue faced by couples across the globe. The purpose of the month is to improve the lives of the millions of people who fail to conceive and due to lack of scientific knowledge. All of we know that infertility is a global burden. About 15% of the total population are infertile. So it must be needed to address how to treat the infertile couple and how to prevent infertility. Infertility management is usually done by following some guidelines like SRM, SRE, etc. But in all cases, these guidelines cannot be followed by all countries due to socio-economic and religious obstacles. So today's webinar will focus on Management of Infertility, Country Perspective. Today, we have as chairperson, Professor T. Chaudhary sir. Sir is the person who need no introduction. Sir is the president of FSSB, former president of OGSB, and sir, former vice president of AFLG. Sir has the highest award of our country, Shadinata Padak, and recently sir has achieved another feather to his crown, the AOFOG Fellowship Award. And we have another chief guest, Professor Rohana Hatatua sir. Sir is a consultant obstetrician and gynecologist, Secretary General AOFOG, and President SAFOC, and sir is the country representative of SPAR. Welcome you, both of you, sir, to this session. We also have as chief guest, we have Professor Moraldhar B. Pai sir. Sir is the Dean of Sikkim Manipal Institute of Medical Sciences. Please welcome sir as chief guest to today's session. As special guest, we have our beloved madam, Professor Gulshanara Begum. She is the Dynamic Secretary General of Obstetric and Gynecological Society of Bangladesh. As special guest, we also have Dr. Thilina Palihawadana. Sir is a senior lecturer, Department of Obstetric and Gynecology, University of Kalania. Welcome both of you, sir, to today's session as special guest. As keynote speaker, today we have two eminent speakers, Professor T.C. Lee, sir. Sir is the president of SPAR, and Professor Budi Wibowo sir. Sir is the past president of SPAR. Welcome both of you, sir, to today's session. As expert panelists, we have four renowned fertility specialists of Bangladesh. Professor Firoza Begum Madam. Madam is the Scientific Secretary, Fertility and Sterility Society of Bangladesh. Professor Rashida Begum Madam, the Honorable Organizing Secretary of FSSB. Dr. Minal Kumar Sarkar sir, Senior Consultant and Coordinator, Fertility Center, Evercare Hospital, Dhaka. Professor Maruf Siddiqui sir, sir is the Joint Secretary of FSSB. Welcome you all, sir and madam, as expert panelists today. So we have two parts in today's webinar. First, we have presentation of two eminent speakers, and after that, we have an exclusive panel discussion session. So first of all, I am requesting Professor Rohana Hatatua sir for the opening remarks. Sir, please. Professor Rohana Hatatua sir.
Thank you, Dr. Umma, for that kind introduction and asking me to speak a few words. So I am very happy to be involved in this today's webinar, but I am sorry that I have to leave for another meeting in a short while. But still, I am happy that I got this opportunity to be in the opening part of the webinar event. So this is a very important or a significant webinar which has been organized by the Fertility and Sterility Society of Bangladesh And I thank Professor Rashida for inviting me for this program. So I am happy to see the Aspire President, Professor Lee, and the past President, Professor Buddhi Viveko, with whom we were working for a long time in the last 2 years, and Dr. Murali Pai and Dr. Professor Feroza Begum, and so many others. And I hear Dr. Professor T. Chowdhury will be here, and he's the great personality who we all recognize and look up to. So today's program is with regard to the fertility month, but we know in this Asian region, South Asian region, there is a population explosion, and there is a rapid increase in population caused by unmet need for contraception, decline in infant mortality, and increase in the life expectancy. And we know the India, Pakistan, Bangladesh, and other South Asian countries contribute to about 25% of the world population. In India, we know there is more than 1.2 billion, and Pakistan 176 million, and Bangladesh 150 billion. So there is a population explosion. So then why are we talking about this infertility? But it is said that every human being has the right to the enjoyment of the highest attainable standard and of physical and mental health. Individuals and couples have the right to decide on the number, timing, and spacing of their children. So infertility can prevent the realization of these essential human rights. So addressing human infertility is therefore an important part of realizing the right of individuals and couples who to find a family. So this is the individual couple whom we are worried about, not the whole country as such. So when you take the individual couple, it is a very significant. Infertility affects millions of people of reproductive age worldwide. Estimates suggest that between 48 million couples and 186 million individuals live with infertility globally. And studies have suggested that after 1 year of having unprotected sex, 12% to 15% couples are unable to conceive, and after 2 years, 10% to have us. So although both women and men experience infertility, women in a relationship with a man are often perceived to suffer from infertility, regardless whether they are infertile or not. So they are the ones who really suffer. So, and infertility has a significant negative social impact on the lives of infertile couples, and particularly women who frequently experience violence, divorce, social stigma, emotional stress, depression, anxiety, low self-esteem, and so on. So they really suffer silently, and sometimes I think they lose their lives also. So for this purpose, it is very important to make our population or people aware of this problem of infertility. For this purpose, there was a National Infertility Awareness Week, which is celebrated from April 24th to April 30th each year. That is to educate and make people aware of infertility. So it has been nationally recognized movement in the United States since 1989. Then the World Infertility Awareness Month, this, on the other hand, is a month-long awareness campaign that highlights the struggles of infertility, increase awareness regarding numerous infertility issues faced by couples across the globe, eliminates the prevailing myths, and eradicates the general social stigma surrounding the discussion of the topic, prioritizes education, and gives community-driven support targeted towards raising more discussions surrounding the concept of infertility and connecting people to the right resources and treatments. So the World Infertility Awareness Month is celebrated every June worldwide. And furthermore, there is a World Fertility Day. This was initiated by Louis Brown, who is the first IVF baby, in 2018. Why Louis dedicated the day as World Fertility Day was to help struggling individuals and couples to break down their inhibitions, concerns, and their struggles due to infertility. So instead of keeping things to themselves and not seeking the right medical treatment, to come out and speak about it so that they can be helped. So more than a celebration, this Infertility Day or month or week, the primary objective of World Infertility Awareness Month or World Fertility Day is to generate clear awareness among people globally and shed some light on the ongoing struggle these men and women face daily. So also we know about this wearing of a pink ribbon to support breast cancer awareness and wearing a red ribbon to support AIDS patients. Similarly, the ribbon for infertility awareness is pink and blue. It showcases your support to infertility and the associated concerns, including pregnancy, loss, stillbirths, birth defects, premature birth, sudden infant death syndrome, and so on. So these programs are very important and essential to combat this problem of infertility, because inequities and disparities in access to fertility care services adversely affect the poor, unmarried, uneducated, unemployed, and other marginalized populations. Also, when we come to the assisted reproductive technologies, which has been available for more than 3 decades, with more than, I think, 5 million children born worldwide from ART interventions, still these technologies are still largely unavailable or not accessible, unaffordable to many parts of the world, particularly in our low and middle income countries. So this is these are things which we know about and which we have to address. And so I congratulate the Fertility and Sterility Society of Bangladesh for having this program and initiating and supporting this month. So I wish this webinar all the success, and I thank you for everyone. Thank you.
Thank you, sir. Thank you very much for your nice and valuable words. Now, this is the time of presentation. Our first keynote speaker is Professor T.C. Lee, sir. Sir is the president of SPIRE, head of Union Hospital IVF Unit, Hong Kong, and specialty is infertility, IVF, ultrasonography, reproductive surgery, and recurrent miscarriage. And we have another speaker also. Sir, please, sir, welcome, sir, Professor T.C. Lee, sir, to talk on management of infertility, Hong Kong perspective. Professor T.C. Lee, sir.
Thank you so much. Thank you. Let me get this screen on. I hope you can see the screen. Is it okay?
Yes, sir, we can see.
You can see that. All right.
Yeah.
Thank you so much. Well, first of all, I would like to say a big thank you for the very kind invitation for me to come along and join this meeting. It's a great pleasure. And I've been asked to talk on infertility, management of infertility, the Hong Kong perspective. First of all, I would like to say, just like what has been said, infertility is a very common problem. 1 in 6 or 7 couples, they do experience infertility. However, infertility treatment is not just about IVF or advanced treatment. It is well known that 80% of couples who experiences infertility do not need advanced treatment or sophisticated treatment like IVF, and they only need very simple treatment. So therefore, in Hong Kong, the way we organize the infertility treatment are at 3 different levels: primary, secondary, and tertiary. And I have to say, this is very similar to what we do in United Kingdom. I spent 30 years or so in UK, and it's exactly like this: primary, secondary, and tertiary care. So what is primary care? Primary level is the infertility can be managed by any general practitioner, any doctor, if they qualify for medical school. But the patient needs to be young, normal ovarian reserve, and no severe male factor, and the duration of infertility should be short. So the doctors, the GP, may do basic investigations and give general advice like folic acid or fertile period, all right? And also they can prescribe ovulation induction like clomiphene for up to 4 cycles. In that way, many couples would benefit from this simple treatment and be able to conceive. If they haven't, or if they have more trouble problems, then they move on to secondary care. Secondary care are managed by specialized obs and gynae specialists. They can be a little older, but still they should be quite young, let's say less than 35, and duration no more than 3 years, no major male factor, and they could offer treatment for up to a year, this doctor. And the type of treatment include ovulation induction, including gonadotropin injections, and also certain type of surgery like myomectomy, ovarian cystectomy, laparoscopic adhesolysis, hysteroscopic adhesolysis, and so on. They could also do IUI, straightforward IUI. However, tertiary level are the care offered by specialists trained in infertility and reproductive medicine, or andrologists. And the patient characteristic are any category, including severe male factor. They could come to the tertiary center, and the treatment include all sort of treatment, including IVF, ART, and these ought to be done in a specialized unit and licensed center. So the way we organize the treatment is making it more efficient, because simple cases are managed by less experienced doctors, perfectly okay. But experienced doctors like yourself, many of you, can spend your time, dedicate yourself into a highly specialized treatment like IVF, advanced surgery, complicated cases, severe male factors that do not respond to a simple treatment. So we found this type of organization is making fertility treatment efficient, worth bearing in mind. The second thing we have in Hong Kong is regulation. So the fertility treatment in Hong Kong is regulated by a Council on Human Reproductive Technology, which is equivalent to HFEA in United Kingdom. I know many of you know about the HFEA. So to do IVF, you need a license to doing it. And then the board, the council would come along and inspect your center at regular interval to make sure that you're doing the correct job, make sure that your results are reasonable, not too poor, all right? Making sure that you know the embryologists know how to handle embryological assessment. And then you have to report the result to the council. For example, if you treated 1,000 cases, and how many of them conceived? Is it 20%, 30%, or 40%? And what proportion of them ended in twin pregnancy or multiple or triplets or quadruplets and so on? So we all need to know about the outcome. It also governs what can be done and what cannot be done in Hong Kong. For example, sex selection, not allowed. Financial reward of gamete donors, not allowed. Egg sharing, not allowed. So many things are not allowed, and the council will stipulate it very clearly. And then it has to be in designated parameters by accredited specialists. Notice the word accredited specialist. You have to be accredited. You have to be recognized by your local society to be an expert. Otherwise, you can't do ART like IVF. The third thing in Hong Kong, we pay a lot of emphasis on, is about training and accreditation. So we have in Hong Kong a college called the Hong Kong College of Obstetrics and Gynecology, which is in many ways similar to the Royal College in UK. It stipulates the training requirement, 3 years of subspecialty training in order that you can provide tertiary care. You can provide IVF and ART. If you're not a subspecialist, you can't provide this type of care. And it also emphasizes on continuous medical education. Now, these are organized by a local society, like the one that you are, the society that you have now. You organize seminars and education activities, and you also collaborate with international society like Aspire, S3 or ASRM, to work together to provide continuous medication for your members, for the subspecialists. So it's like a brotherhood or a fraternity in a way. And we also focus not just on ART, but also on reproductive surgery. Now with that, I want to say fertility treatment is not just an IVF. It should be a wide range of treatment. It should be a comprehensive range. For example, when we talk about surgery, this is just an example. We train our trainees how to do laparoscopic and reproductive surgery. Tubal block is not only treated by IVF. For example, it can be treated by a very simple procedure like this. This lady has got a block in the right tube, proximal block here, all right? And this is confirmed by hysteroscopiogram and also by this laparoscopy. And I want to show you a very simple thing that we teach our trainee. So you can see when you put a dye, that tube, left side is open, the right tube is blocked, no dye through, just like what a hysteroscopiogram. So in the past, we would do reconstructive tubal surgery by removing the block segment and then joining it back together. So tubal surgery. But you see a simple maneuver that we do in Hong Kong and in UK. I only clip the tube slightly on the patent tube and I put the dye again. You see, now this tube is now being flushed open. So hydraulic pressure very often can overcome a block due to mucus plug. We teach our trainee this. This patient doesn't need the IVF. She can see 4 months later. Fantastic. No need for advanced IVF treatment. So we need to provide a comprehensive range of fertility treatment, not just IVF, simple surgery. Another thing about training is we need to train about cost effectiveness. There are many treatments available, but which one is more cost effective? For example, ovarian diathermy. Well, should we do ovarian diathermy or should we go to gonadotropin? There has been several trials, several publications suggesting that laparoscopic ovarian diathermy like this is more cost effective. Like this one is very simple. You make 5 holes and then each hole 5 seconds. So 3 holes already, and then make another one. 1, 2, 3, 4, 5 seconds. Make another one more. This is a very simple procedure, and yet it makes it not necessary to have gonadotropin treatment, which is quite expensive. Monitoring is also expensive too, and if you don't monitor it carefully, you got multiple pregnancies. So many trials had confirmed this simple technique is effective. So cost effectiveness is very important, especially in a country like us, where even though people can afford it, it would be good to be able to achieve a result without too much expenses. Well, there has also been many randomized controlled trials from Scandinavia suggesting that if you got hydrosalpinges, it will be more cost effective to remove the tube first before doing IVF. So this is based on randomized controlled trial. If you do not do a surgery, the cost, the cost per live birth is 29,000 euro. But if you do the salpingectomy first, it will then remove the fluid, the hydrosalpingeous fluid, leaking back into the uterine cavity, and then you are less expensive, 20% less expensive than if you keep on doing IVF. So cost effectiveness is important. And also, we are also training our specialists to offer safe treatment. Training is about safety. For example, how to avoid OHSS, how to avoid multiple pregnancy, and how to avoid surgical complications. Another example of surgical complication, if you do tubal cannulation, one complication is perforation of the tube. So for example, when you see in this case, when you're doing a tubal cannulation, you see the tube is kinked here. If you push too hard, you can perforate the tube. But in order to avoid perforation, what you ought to do, you see, if you push, you will perforate because it doesn't bend like that, acute bending. So in order to straighten the tube, you have to move the uterus away or the tube away from that bend. I'll show you in a minute. So if you push, I'm sure it will get perforated. So notice, so move the uterus away from it, you can straighten the tube. All right, then if you cannulate again, now it will be safer. So one trick for tubal cannulation is to observe by laparoscopy and straighten the tube. And this one is remembering not to cannulate too far. Just cannulating 2 centimeters is okay. You don't need to. So this one you can see, this surgeon is too ambitious. You know, you cannulate too much when you observe it. If you cannulate too much, too far, and you will perforate the tube. Look, look, this is almost perforating now. So it's not necessary. Don't be too ambitious. So we train our staff to do safe surgery. Training is important. And also we train them to think about innovation treatment. For example, this one with Ashman syndrome. Let me see whether I can may affect your quality. So, sorry, this doesn't seem to play. Okay, it's all right now. So this lady has got Ashman syndrome. She's a nurse. So when you see it in the past, we will arrange a GA, general anesthetic, to remove the tube. But this case was completely done under no anesthetic, no touch technique. All right. I don't even have to put a speculum. So this one you can gradually remove the adhesions using simple outpatient hysteroscopic technique and no touch technique. And then 6 weeks later, when you do a follow-up second look, all the adhesions have gone on the same patient. So this is innovation, simple, safer, and effective. So for example, another innovation is to removing adhesions or preventing adhesion using this balloon technique. So you pick a Foley, inflate it, cut away the tip, and then you put it inside the uterus and inflating the cavity. By doing that, you can remove and stretch away the adhesions and also preventing them from occurring again after you've done your primary adhesiolysis. So this is innovation, simple. We like to offer simple treatment and yet safe treatment. And also we have, I might have shown it to you before, this what I call invisible knife. So adhesions, you can see at Ashman syndrome, but now you can see the invisible knife is now separated adhesions. This is just hydrodissection, using the jet water, shooting at the adhesion, and you see it can open up like an invisible knife, remove and cut away the adhesion. Again, these are all done in outpatient department. I don't need any anesthetic, making it safer, less expensive for the patient, more appropriate. So training is very important. Training accreditation would raise the standard of treatment by providing a comprehensive range of treatment, by offering cost-effective treatment, making safer treatment and innovation of treatment. By raising standard, you will provide good clinical outcome. You increase the success rate. And then because of that, your patient will be more satisfied. And because they're more satisfied, you have more patients coming through, and you can develop your clinical service better because you got a better reputation and a greater profile, and you got more revenue to support further development, and your staff will be happier. Staff morale is very important. If you're doing a good job, your staff would be happy because they know they're working in a good center. So training and accreditation, it's all seems to be very easy, but how can we do it better? Well, I think we need a commitment. I'm pleased to know that your society, Fertility Society of Bangladesh, is organizing all this activity. I think as a group of senior doctors like yourself sitting here in the Zoom meeting, by organizing it, committing yourself to raising standards and getting better training for the doctors, specialists in your country, it needs some organizational commitment. Regular seminars and regional meetings, exactly like what you're doing, organizing a meeting, getting some people to come along and share their views and experience. But we need a national training program. It would be good if the society can work together and provide a national guidance on what is required to be accredited. What are the basic minimum requirements? And like a college, like a society, you can work together to produce a standard. Industrial support is important. If you want to organize the program, working with industry, they can give you support and making it working faster. But also you can get support from international collaborators like Aspire. You got such a good working relationship with Aspire. I think it would be appropriate to perhaps work with Aspire to produce certification or accreditation. Aspire have recently set up a new accreditation committee. I think Professor Rashida knows about this in quite detail. So by working together, maybe we can join hands and work out some accreditation standards for your subspecialists and making sure who is qualified to providing the care and and also patients are very clever nowadays. If they know that this specialist has been accredited, they have more confidence, they're more likely to come to you. So I think working with international organization is a plus. At the end of the day, I think to move forward, we need to say several specialists need to be certified and accredited. Same in America, ASRM, you need to be certified. In UK, in Europe, you need to be accredited. In Hong Kong, we need our specialist to be accredited. So maybe looking forward, there is a accreditation program. It would help. I'm sure that would help to raise the standards. It will ensure good training, and then it will bring all the benefits. So if I may summarize what I just briefly shared with you, the treatment in Hong Kong, I think we ought to think about efficiency via organization, different levels of care. Specialists like yourself and myself should focus our time in handling more sophisticated, complicated cases. We will leave the simple cases to our more junior colleagues. We need to have guidance through regulation. We need to have a society, maybe a council or whatever, to say what can be done, what can't be done in the country. It's important. We need to have training and accreditation, raising the standards, comprehensive range of treatment, minimal complications, cost effective, are very important, innovations. And we have to get commitments, industrial support, work with international organizations, and aim for accreditation or certification. I think with that, I can see a promising future for the fertility treatment in your country, and I'm sure there will be room for improvement as we go on. So with that, I'd like to thank you once again for the opportunity to share with you what we think about fertility care. Thank you, and once again, thank you.
Thank you, sir. Thank you very much for your excellent, evidence-based, and very informative presentation. And I think you perfectly judged on your topic. Our next keynote speaker is Professor Budi Wiweko, sir. Sir is the immediate past president, Asia Pacific Initiative on Reproduction, that's SPAR, and Vice President, Vice Director of Indonesian Medical Education Research Institute, Faculty of Medicine, and Universitas Indonesia, and member of Advisory Board of Mark Serono, Asia Pacific. So please welcome, sir. Sir,
thank you very much.
Please welcome. I welcome sir to deliver her presentation on management of infertile women with very low MH, that is less than 1 nanogram per ml Indonesian perspective.
Thank you very much, Madam Chairpersons, and good evening. Good evening, everyone. So I'd like to thanks to organizing committee, my friends, Professor Maruf Siddiqui, Professor Rasida Bigam, and Professor Ferdowsi Bigam, that's already inviting me to share Indonesian experience in managing post-responder patients. So just continuing what Professor T.C. Lee just presented before, so it's very important the management of post-responder patients, Indonesian perspective, that Indonesia is one of the biggest Muslim country in the world. So we did not recognize any donation, and also we did not recognize any surrogacy policy in every IVF procedures. As we know that very low AMH level are associated with relevant risk of cycle cancellations. So I think there is no standardized protocol in managing of poor responder patient, even in the world, even in X-ray guidelines, there is no standardized protocol, which one is the best actually what we can do to our patients. I will present some cases for poor responder patients. For example, the first case, Mrs. 38 years old with a secondary infertility, and then she has a menstrual regulation, regular menstruation, and then she has a 2-time history of failed of intrauterine inseminations, and also she has a previous 3 times IVF failed. And if we look this one here, her BMI is 20.2 kilogram per meter square, and she has a low MH of 0.9 nanogram per milliliter. So we decided to continue the 4th IVF cycle by antagonist protocols. If you look this kind of protocol, we started with the high dose gonadotropin with 300 IU, and then starting from supplementations. 100 I think 75 LH supplementation starting from day 5, and also adding by 150 FSH. So daily in total is 450 IU of FSH plus LH supplementation 75, and then totally it took 11 days of stimulations before we do the triggering with the HCG, and then we succeed to retrieve 7 oocytes. 6 of them are mature and then underwent ICSI. And on day 3 of day 5, sorry, on day 5, we have only 2 embryos, 2 blastocysts. And then considering that she has a history of 3 times IVF failure, so we underwent PGTA. The first blastocyst revealed the chaotic pattern of chromosome of blastocyst. And then the second blastocyst, fortunately, she has euploid embryo. Then we replace 1 single blastocyst transfer, and then 2 weeks after ET, her HCG level is 1,500 with her progesterone level 8.1. And then the patient now is successful ongoing pregnancy and has been delivered her baby. The second case also, this is the very old lady, very advanced maternal age. She has a 48 years old and already suffering from 11 years infertility. Sorry, I think there is some okay, she is 48 years old, and then her AMH is 0.03 nanogram per milliliters. Fortunately, she still has 2 untransferred count. And then directly we started with the high dose gonadotropin for ovarian stimulation, and then also supplemented with growth hormone and LH supplementation. it took also 10 to 11 days stimulation, and then we succeed to retrieve two oocyte on the egg level, and one of them becoming blastocyst on day 5. And unfortunately, when we perform PGTA, the result was trisomy 18 and trisomy chromosome 21. So we did not perform ET for these patients because of this is a lethal, this Edward syndrome and Down syndrome. And the third case also, this is a lady, 42 years old, is suffering from primary infertility for 15 years. And she has a very low, again, very low AMH level, 0.01 nanogram per milliliters. So before we started the stimulation, of course, we consult the patients regarding the success rate, and also regarding the risk of cancellations of for each cycles. And we started with the high dose, 375 IU for recombinant FSH combined with growth hormone. And then again, we do the trigger after the 10 days, after the 8 days stimulation, we trigger with HCG, and we successfully retrieve 3 oocytes. And in the first oocyte retrieval, and then one embryo was frozen. During the egg retrieval, we see that there's we see there's some small anther follicles, and then 5 days after egg retrieval, we continue with the luteal phase stimulation or double ovarian stimulation, also with high dose gonadotropin. And then on this patient, on the second oocyte retrieval, again we succeed to retrieve the oocyte, and then one embryo was frozen, but it's not so good and poor quality. So in this case, we frozen 2 embryos with the double ovarian stimulations. And then the fourth case, this is about the Mrs. 38 years old with endometriosis. She has undergone a history of laparoscopic cystectomy, and then no history of IUI and no history of IVF. And then her AMH level of 0.5 nanograms with good sperm quality, and she has a FC 6 follicles. And we do the ovarian stimulations with high dose gonadotropin in long protocol, combined also with the recombinant LH, and also we combine with growth hormones. We succeed, retrieve 8 oocytes with the fertilization rate 50% and then cleavage rate 62%. In this case, we replace all the 3 embryos. This is blastocyst, 2 blastocysts, and then 1 early blastocyst. And 2 weeks after ET, we have a very good level of HCG, and now she has an ongoing pregnancy. So if you look this one, all the cases with the poor responder. So number one, in the first case, we did the ovarian stimulations and with the PGTA, and then case number 1 and number 2, both of them we did the PGTA. Also, it depends on the patient's willingness and also the patient's the funding as well is very important, because in our country, IVF should pay by their own. And then the third case, we did the double ovarian stimulations. And then the fourth case, this is the endometriosis patient. So as also is our study in our center, looking for what is the important case in the poor responder patients. Among 700 patients, we have 188 poor responder patients. And then I think this is the sum variable is significantly, statistically significant. It was age, and also endometriosis in our center is significant, important factors as a cause of poor responder patient, and also history of ovarian surgery. So I think what Professor Tisile mentioned regarding the training in laparoscopic surgery, it is very important because in our center, it was proven that the history of ovarian surgery play important role to make a patient fall into poor responders. This, for example, most likely, yes, in endometriosis, the poor responder patients, and also a history of ovarian surgery. And if we're trying to divide the poor responder into category of Poseidon 1 until 4 in our centers, it looks both of endometriosis, both of endometriosis and history of surgery is very important factors to make the patients come into poor responder. For example, in Poseidon group 1, even the reserve is still good. However, the response is quite it's worse because of there is an endometrioma. And also in Poseidon group 2 and 3, in group 3, because of history of ovarian surgery, even the patient still below than 35 years old, the ovarian reserve is lower because of history of ovarian surgery. And also history of ovarian surgery also can decreasing the ovarian response even in the patient with good ovarian reserve. And also in Poseidon group 4, the patient above 35 years old, decreasing of ovarian reserve also because one of them is because of her history of ovarian surgery. And this is also our effort, trying to educate the patients how they should know about the ovarian reserve, the biological age. We established the formula, we call it Indonesian calculator of oocyte, based on serum AMH. So in this study, we measure AMH level in reproductive women, and most of them they know that they have a biological age, and also half of them knowing what is the biological age marker, which is AMH, and then they agree that women should be advised to check their ovarian reserve. And also I think most likely they are the age between 25 to 35 years old, that they are willing to be checked the ovarian reserve. And then also 30% of them are willing to spend money to check the MH level. And then what is their attitude after they know the serum wave MH and the tendency for reproductive technology choices? After they know that the level of MH is getting declined, most of them immediately getting married. 40%. This is their answer. And then also most of them are willing to have or add more child if they know that the reserve is getting declined. So, and also 33% of them also willing to do the oocyte cryopreservation. Even in Indonesia, social egg freezing still in controversial issue, particularly if the patient is not getting married yet, because in the Muslim country, this is one of the issue that still not regulated yet by our government. So based on the situation and also based on our experience in Indonesia, so most likely we are trying to hard to manage our patient by releasing the residual follicles into responders with the philosophy is squeeze the ovary. Of course, it's not so easy. So that's why if you look the Poseidon criteria 1 until 4, we are trying to do to manage the responder patient by increasing effective dose, and then also adding some L8 supplementations, growth hormone supplementation, and also preparing them 3 months before if they are willing to prepare 3 months before the stimulation by adding the androgen or even the substrate androgen supplementation, and also coenzyme Q10. So this is the decision making in our center for the poor responder patients. First of all, we should decide whether the patient below or above 35 years old. And then I think it looks like it's a green, it's Poseidon 1. And also this is in the blue, it's a Poseidon 2 with above 35 years old with the adequate ovarian reserve, but might be this is a green and blue is a good prognosis. And then this is in Poseidon 3 with inadequate ovarian reserve, below the 35 years old. And then this is the worst is Poseidon 4, patient above 35 years old with the inadequate ovarian reserve. And we use cutoff point AMH is 1.2 nanogram per milliliter based on our study in our center for Indonesian women. We use 1.2. And then also we use a cutoff point 6 follicles for both ovary as a cutoff point of anti-follicle count to determine the ovarian reserve. And how do we manage all the patients? After we decided the patients in Poseidon 1, 2, 3, or 4. So basically, of course, this very difficult one is Poseidon 3 and 4. So number one, if the antifollicle was detected, we can start the stimulations, trying to releasing residual follicles, even by conventional or even by random start stimulations. And then we suppose that we plan to have the frozen embryos. This is we perform high dose gonadotropin, LH supplementation, growth hormone, egg retrieval, and then doing double stimulation. Even double stimulation also is a big problem in Indonesia because of cost. Because in double stimulation, it means the patient should pay twice for egg retrieval. Even we now most likely we prefer to freeze the egg first, and then after the double stim, the second egg retrieval, and then we do the injection by ICSI concomitantly with the oocyte retrieved by first egg retrievals. And the last, counseling is very important. Counseling, including adoption, in the patients with the Poseidon 4 that very low MH, even like in second case, even in 48 years old, we still trying. They insist to have a children by their own gametes. We still insist to start the stimulation with the good counseling. Even after that, we counsel the patient to maybe they're willing to adopt to make an adoption of the children. So I think this is the situation in our country that is very much problem in facing the poor responder, particularly because we are not recognized the policy of donation, and also we are not recognized policy of surrogacy in managing of poor responder patients. I think this is my presentation. Once again, thank you very much for inviting me to sharing our experience in Indonesia. Thank you very much.
Salma, unmute yourself. Salma, unmute yourself. Okay.
Thank you, sir. Thank you very much for your excellent talk on a very time-demanding topic. Now I'm just going to panel discussion session. Our 4 expert panelists are Professor Firoza Begum, Madam. Madam is the Vice President of Obstetrical and Gynecological Society of Bangladesh, President Fetal-Maternal Medicine Society of Bangladesh, and Scientific Secretary, FSSB. Professor Mohammad Rashida Begum, Madam, Vice President OGSB, Treasurer SPAR, and Organizing Secretary, FSSB. Dr. Minal Kumar Sarkar, sir. Sir is the Senior Consultant and Coordinator, Fertility Center, Evocare Hospital, Dhaka. Next slide. Farzana, next slide. Professor Maruf Siddiqui, sir. Professor and Departmental Head of Infertility Reproductive Medicine, Anwar Khan Modern Medical College Hospital, Joint Secretary, FSSB, and Country Representative, SPAR. Now there are 4 scenarios for 4 panelists. First one for Professor Firoza Begum, Madam. Mrs. X, 39 years old lady, has come with the complaints of primary infertility for 18 years. Husband's semen is normal. At the age of 37, she visited for the first time to a gynecologist, where she has diagnosed as a case of fibroid uterus. She has been treated by ovulation-inducing drug. Now at the age of 39, it is found that her AMH is 0.3. There are two fibroids, one in anterior surface, which is 4 by 5 centimeter, and other is in posterior surface, 4 by 4 centimeter of the body of the uterus. The cavity is distorted by the posterior one. So, madam, how will you manage this case? Madam, please. Professor Firoza Begum, madam.
Firoza madam, please unmute yourself first.
Okay.
Yep.
So we all know age is the single most important factor affecting the fertility outcome. This lady, she's, can I see the scenario? Then it will be better if you show me the scenario. So this lady, she is now 39 years. She is trying for pregnancy for last 18 years and was treated by several cycles of ovulation inducing drugs. And we know with age, a woman fertility decreases because of the age-related increase in many conditions like fibroid, endometriosis, as well as age-related increase in the chromosomal abnormality. In this case, she has now developed two fibroids and one is distorting her cavity. Though fibroids in this size, a patient can conceive, but as the fibroid has distorted the cavity and it will interfere with the implantation. And regarding her age, we all know, previously we knew that the fertility declines sharply at the age of 35. Now it is, we know in this region, the fertility declines at the age of 33 and her AMH is now 0.3. And different authorities has mentioned that the lower level of AMH is 1.2 and somebody says it is 1.5. And the poor responder, or this is the very low AMH when the AMH level is 0.03 or 0.04. And it is possible to conceive at this AMH, but because of the age-related increase in the number of chromosomal abnormality, it will be difficult for this woman to conceive, but still we can, if she can afford, we can give her 3 successive cycles of ovulation induction, as Dr. Buddha has mentioned, very high dose of gonadotropin, and we can collect the oocytes and make the embryos, freeze them, and after 3 or 4 cycles, we can do an ET. But before that, we have to remove the fibroid, which has distorted the cavity. This is all from me. Dr.
Thank you, madam. Thank you very much for your logical approach to the patient of that scenario. Respected other 3 panelists, would you please want to add any point or have different opinion?
Okay, can I add something?
Yes, sir, please.
Madam, she has got 2 fibroids and one is distorting the cavity, and she's already 39 and the image is 0.3. So definitely we can go for 1 to 3 cycles, collecting 3-4 embryos, freezing them. But can we just, I think we can do it earlier. Freeze them, make 4-5 embryos pool, and then go for myomectomy.
Yes,
and
I have said it. Okay. Probably you could not follow me. I have mentioned it. That we will go for 3 or 4 cycles of ovum pickup, freeze the embryo. Then I will go for removing the fibroid that is distorting the cavity.
Okay, madam.
That is my opinion. And because, but still we will not disappoint her. But this is very difficult in our country, Maruf. We know that one patient cannot afford a single cycle of IVF. How she will afford 3 or 4 cycles of IVF? That is the most important part. That is of my concern. But still, we should encourage her. We can give her some hope.
I think in most of the cases where oocyte donation is accepted, most of the countries would go for oocyte donation. So can we have the opinion of Professor Buddhi Viveko, because donation is not accepted in Indonesia? You have any other opinion regarding this case?
No, I think I agree with both of you that we should proceed to do IVF, and then the best, of course, we frozen the embryos. Afterward, we do the resection of the fibroid, And then maybe 6 months after the resection, we can replace the frozen embryos.
Can I share, Dr. Maruf?
Yes, Appa. Please, Salma is the moderator. Please.
Thank you very much. And this is a question to Firoza Appa, is very practical one. And I am also practicing like this. First collecting the oocytes, making embryos, then myomectomy, then going for EA. Because if we do myomectomy beforehand, the OPU, there will be lots of adhesion. So difficult to do OPU, and further AMH may be further decrease. So it gives a good result. If we do myomectomy and give FET, we found the result good. I'm also practicing just like this. Thank you, Appa.
And can I add one more thing, that this is the country situation, and I think this is the country problem in Bangladesh. She has been married for 18 years, 18 long years. So she should not come to a scenario like this with 2 fibroids at 39 years and with AMH 0.3. She should have been treated much earlier by other gynecologists. I think that would have been a much better outcome. Thank you.
Yes, thank you.
So thank you, sir and madam, for a lively discussion. So the second scenario is for Professor Rashida Begum, madam. Second scenario, please. Mrs. Y, a 35-year-old lady, has been suffering from endometriosis for 9 years. 5 years back, she underwent laparoscopic bilateral cystectomy for 4 by 5 centimeter and 5 by 6 centimeter endometrioma, when her perioperative AMH level was 1.21 nanogram per ml. There is recurrent endometrioma in both ovaries, adherent with the posterior surface of the uterus as kissing ovaries, and AMH level is 0.2. Madam, what should we do when our preoperative AMH level is 1.21 nanogram per ml with bilateral endometrioma? And the second question is, how will you manage the case? Please, madam.
Thank you, Salma. My apology that I have seen your cough and my voice is a bit low. First of all, I want to thank both the speakers for their very informative and excellent talk. Particularly in both the countries, they're not used to practice ovum donation or egg sharing. So situation is like ours. In our country, though there is no rule, but from Islamic perspective of view, we are not religiously allowed to do ovum donation or egg sharing. So scenario is same. So I wanted to know how do they manage their case with such poor responding patients. So from this scenario, first of all, you ask that what should we do when AMH level is too low when in bilateral endometrioma. We know in case of bilateral endometrioma, if we do cystectomy, the chances of ovarian failure is previously it was told that 2.4%, but recently I saw in the article it is 18%. It's too high. And in a recent article, it is described that if AMH level is less than 2.5 in case of unilateral endometrioma, then surgery should be omitted. And in case of bilateral endometrioma, if it is less than 3.5, then in case of unilateral, 2.5 is okay. But in case of bilateral endometrioma, it must be more than 3.5. So in that case also, cystectomy should be omitted. Then what should do? The patient must be treated by ART. But problem is, like our country, ART is not feasible for every patient. Most of the patients are poor, they cannot afford ART. So there is problem, and people are going to do cystectomy. But for this patient, if we counsel them, and if they can manage some amount of money, we can consider the patient. And in my opinion, patients of this profile, they must do ART earlier than later, and to reduce time for life. But particularly in endometriosis, you know, AMH level becomes lower due to presence of endometrioma itself, and surgery will aggravate, and she may undergo failure. Her AMH is very low, and within short time she lost all of her eggs. The second portion, what we'll do? I do what Budi mentioned. I do ART even with MS level 0.01, and I got pregnancy from MS level 0.17. So it is challenging, and we must have to take this challenge from both part, from patient's part and from clinician's part. We both have to take this challenge. But MS is least MS, but it is not like that. That her ovaries are empty. Her follicles are reduced significantly, but ovaries are not empty. There are some amounts of eggs, and which Buddhi shows that we have to squeeze the ovaries to get even on single egg. I got number of pregnancies with single egg. If patient's age is low, 1 or 2 eggs may give pregnancy. So I will go for ART for these patients. Usually I prepare the patient, I give pre-pregnancy, pre-ART treatment. I add coenzyme Q10, but because we know the patients of egg of the endometric patients are quality a bit lower. There is reduced number of mitochondria and abnormal mitochondria. So no, mitochondria is the powers of the cells. It is needed for cell division and further growth. So coenzyme Q10 and DHA, they both are important for synthesizing or repairing mitochondria. So I use 3 months coenzyme Q10, a bit higher dose, 200 milligram 2 to thrice daily, and DHA. After 3 months, I stimulate the patient. Usually, first 4 days recombinant FHS. After that, I use. We don't have separate recombinant LH and recombinant. We have recombinant FHS, but we don't have separate recombinant LH. But we have combined recombinant LH FHS parvovirus from Seroro. So it is very expensive. The patients who can afford parvovirus start parvovirus from day 5. Patient who cannot afford parvovirus, I go for menopausal gonorrhea, human menopausal gonorrhea. It contains LH. So these patients need LH during their folliculogenesis. And if patients are elderly, then they must need LH. So I use recombinant FHS for 4 days, then for LH and FHS. And 2-3 egg collection, maybe if patient can afford, I give dual stem protocol use. Some patients can afford and collect the egg, freeze eggs, then after that we transfer this. We don't have the scope of PGT. So for elderly patient, we transfer the embryos, whatever maybe its quality. But in elderly patients, it is ideal to do PGT to select the appropriate embryo. So this is the scenario of our patients, which is same in Indonesia and also Hong Kong, that they are face their patients with very low MH, and after that, patients can actually most of our patients, they become satisfied that they tried, failed, and they go for adoption, and someone if failed and they don't do anything, they become childless and they become happy. So donation is not the answer for these patients. If we can challenge, if we can take this challenge, we can give them baby, and after trying, if they fail, then they realize that this is the fate of nature. Thank you, Salma.
Yes, madam. Both bilateral.
Dr.
Yes.
Salma, I have one question. To
Madam,
Dr.
please.
Can I ask one question?
Madam, please.
Professor Rashida, will you give any message to the obstetricians regarding this patient, that when she should be referred for infertility specialist? I think this is very important, because you give so much, we do several cycles of IVF. I believe more than 98%, 99% patient cannot afford several cycles of IVF. So, and it will cause breakup of the family. So what is your message for the general obstetricians?
Thank you, Appa, obstetricians, gynecologist. Actually, Professor T.C. Lee narrated very clearly that there are 3 levels of infertility management: primary, secondary, and tertiary. secondary labors, patients must be less than age 35 years. It is the recommendation of ASRM. Patient's age must be less than 35 years. Duration of infertility must be less than 3 years. And there should not be any severe male factor infertility. And nowadays, it should be added that AMH should be optimum. If there is low AMH, it must be referred to higher setup. So if age is more than 35, duration of infertility more than 3 years, they must be referred to a special center. And if there is, I suggest if there is bilateral endometrioma, the patients must be referred to person who are very efficient to do the laparoscopic surgery in endometriosis. In beginners, they must have not tried for laparoscopy in case of bilateral endometrioma.
Thank you.
Can I
Thank you very much.
ask a question? Rashida to Dr. Rashida.
Yes, madam. Please
Okay,
put
thank
your
you.
question.
Dr. Rashida, which protocol do you prefer for endometriosis, short antagonist protocol or long protocol with GnRH agonist for 2 or 3 cycles beforehand?
Antagonist, I use mostly antagonist.
In case of endometrioma also, you prefer?
If cyst size is bigger, then I aspirate the cyst. I use ethanol, and after cyst aspiration, I wait for 2 to 3 months. At that time, I suppress with other drugs, not agonist, because if I use agonist for a long time, the requirement of FHS will be very high. So we have to cut the cost also. So I use either Dynogest or OCP for 2 to 3 months, then go for antagonist protocol.
Yes, there are studies where they shown that if we give a 3 cycle or 1 or 2 cycles of Zoladex or GnRH agonist, so that is good for the size of the endometrioma. They showed is good for, but I think regarding the result may be same, but for the size of the endometrioma, maybe some suppression, then we give stimulation. So I saw in some journal that gives good result.
But you know, the recent ICSI guideline, it clearly mentioned that long down regulation is no more recommended because it suppresses the pituitary so much that it needs
more gonadotrophin. Okay, thank you.
Can I say something, Salma?
Yes, sir.
I think apart the patient is 39 years and endometriosis, so definitely we should put her on an antagonist protocol. That would reduce the cost, and we would have a much better chance of developing a follicle. And with the permission of Salma, can we have the opinion of Professor TCD regarding this scenario?
Yes, sir. You can see, we can take a valuable opinion for Professor T.C. Lee, sir.
I enjoyed the discussion. I think it's a very interesting case, very controversial in some aspect. I personally think there is no correct black and white or answer to that. I think it's the patient's preference and the clinician's skill is important. But I have just highlighted one thing. Based on a randomized controlled trial from Hong Kong, published 18 months ago in BJOG, I think the conventional wisdom of doing operation on the ovary and compromising ovarian function is not necessarily true. We have many cases of endometrioma. After very careful surgery, actually the AMH goes up and the FSH comes down a little and AFC improve, because by removing the endometrioma carefully, you reduce the pressure onto the remaining ovarian tissue. You can improve the outcome. So I think the secret is how careful you do the surgery. And this is where training is so important. Don't burn the ovary. Strip it very carefully. Don't use excessive diathermy. And we use flow seal, chemical sealant, prothrombin sealant to seal on the surface as careful as we can. And nowadays, even though we do majority of cases by laparoscopy, if it is very difficult, we are not hesitant to convert it to laparotomy in a small proportion of cases when they're very stuck down. Because the key, the training is to protect ovarian function. Whatever we do, we ought to protect ovarian function. Sometimes during laparoscopy, it bleeds and it causes more problems. So I think doing it very carefully with confidence and in specialized hand. I think my threshold for doing endometrioma surgery like that is not as high as before. So there is a certain opportunity to improving ovarian function, in fact, after surgery. So that's the point that I want to make. But I think I can see how interesting this is. Life is interesting because there are so many ways of looking at solving the problem. Thank you very much.
Thank you very much, sir. The next scenario is for Dr. Minal Kumar Sarkar, sir. Sir, Mrs. Z, a 34 years old lady, has come with the complaint of primary infertility for 7 years. Her cycle is irregular, but there are no other features of PCOS. Her husband had a history of previous marriage and he has a son of 7 years old. She took almost 20 cycles of induction with clomiphene and letrozole. Semen analysis was never done. You evaluated the couple and found that the women's FSH, LH, and E2 all are very low at the level of hypogonadropic hypogonadism level. So, sir, what do you want to do now? Dr. Minal, sir. Dr. Minal, sir.
Mrinalda, can you hear us? I think he's
okay, sir. We'll go for next scenario. Scenario 4 for Professor Maruf Siddiqui, sir. Sir, Mrs. X, a 28 years old lady, has been suffering from primary infertility for 5 years. 2 months back, she went to a gynecologist who advised all investigation, including hysterosalpingography, in her first visit. During follow-up visit, when she has come with all investigations, it is found that her husband is agiospermic. So, sir, what should be the approaches of investigation for an infertile couple? Professor Maruf Siddiqui, sir, please.
Okay, thank you, Salma. I think after following very complicated situations, this is a much easier scenario for me. The patient is young, 28 years. I think the basic problem was made that giving an HSG in her first visit. Because maybe you should always proceed for a tubal assessment after you get the semen analysis report. So at the first visit, of course, you should proceed for basic investigations. A basic TBS will give you, which is usually a bedside investigation. It gives you an idea about the uterus, any cystic ovaries, any cyst in the ovaries, any chocolate cysts and other things. A basic blood sugar profile and thyroid hormone profile should be enough. And in our scenario, we always have to go for the semen analysis. And this is a problem we sometimes face in Bangladesh perspective. The patients comes to us and say that my husband is okay, please treat me. And sometimes the husband said, no, I will not do the semen analysis, please treat my wife first. So these are the problems, but we should always keep in mind that first, my personal opinion is that if the patient is cannot afford many investigations, if we have to give only one investigation to the patient before resuming ovulation induction, that has to be semen analysis. So I think the basic problem of this scenario was doing the HSG in her first visit. Maybe doing the semen analysis in the first visit, and if and if the gynecologist found that the husband is azoospermic, obviously there is no rationality for assessment of the tuboperitoneal factors following that. So this is a very basic problem. Maybe she has done it. She has thought that it would be a problem for the patient to come back over and over again. So let's give the investigations all time in the first setting, but I think that's not appropriate. We should always proceed for a tubal assessment, either HSG or whatever type of tubal assessment you want to have after you get a totally normal spermic semen parameter in your hand. Thank you.
Yes, sir. Approaches to evaluate the infertile couple have to be stepwise, and thus we can skip very unnecessary investigations. Thank you, sir. Thank you for your practical answer regarding the scenario.
We should discuss about Mrinal's scenario. Is he here? If Mrinal is not here, we can discuss.
We can discuss the scenario. You can please get back to the scenario. Scenario.
Please,
Yeah.
Scenario number 3, please, Farzana.
Remember that patient, that woman has hypogonadotropic hypogonadism. Here is fitful is without doing semen. This is gross mistake. Without doing semen analysis, she got more than 20 cycles induction. So this patient, he would be severe oligospermic or isospermic. But in case of female partner, if she is hypogonadotropic hypogonadism, then there is no use of clomicetate and letrozole. There must be some abnormality in hypothalamus or pituitary. So clomicetate and letrozole will not to work in this case. This patient needs gonadotropin and HMG. That's gonadotropin who has got both LH and FSS. So this she lost her valuable time with taking this treatment. So we must have to again I have to go to TC list lecture that due to classification of these different category like primary, secondary level, we should, if ovarian volume is very small, patient has irregular cycle, we should do biochemical test. And FC count is very less, we should do MH. If MH, FHS, LH, it will. If this patient did FHS, LH, it will earlier, then she would be identified as hypogonadotropic hypogonadism, and she must be referred to higher center, because this sort of patients also must be dealt with a consultant of tertiary level. So this is the message that if irregular menstruation is not always for PCOS. It may be premenopausal woman, ovarian insufficiency, or hypogonadotropic hypogonadism. So we must do ovarian reserve test at some point.
Dr. Rashida, any advantage by doing karyotyping?
Karyotyping is far advanced. Rather than you can do a transvaginal ultrasound and count the antral follicles, that will give you a better result. Karyotyping is not still available in all laboratory in our country. Only BSMMU is doing it and giving the result after 3 months.
Yes.
So this is a long time of waiting.
So I think the take-home message for this scenario is we should have 2 take-home messages. That is, the patient the cycle is irregular, but still there is no PCO. So for the primary physician should have referred her immediately to the tertiary physician to find out what is the exact cause. But by the time 7 years has already gone back, and there's no justification giving clomiphene and other things without the correct diagnosis. That was the problem. And the second thing, I think that the husband, though he has a previous marriage and a son, but still in giving drugs, we should proceed for a semen analysis. But many of the patient who already has normospermia and 1 or 2 children, sometimes we found that severe oligospermia or even azoospermia.
So
secondary cause.
Dr. Salma, I can ask one question to our expert speakers, Dr. Lee or Dr. Budi. Both of you, any one of you can answer that how many cycles actually you give ovulation induction, because it is a common practice here that we give several cycles of ovulation induction. Is it rational or it is not rational?
Professor
Yes.
Budi, sir, please.
Yes. Thank you very much. Actually, the first thing that we should do in anovulation cases, that we should define actually what is the etiology of anovulations, whether this is WHO class 1, class 2, class 3, or class 4. So that's why after we define the diagnosis, we can determine what type of medication we can offer the patient for ovulation induction. For example, in these patients, when the patient came to us with irregular cycles, so most likely they are suffering from anovulation. So we should check definitely, immediately, which type of WHO class this patient is suffering from. So if we look this one, after 7 years, of course, within 7 years, the physician did the ovulation induction without knowing actually what is the etiology of anovulation. So I think this is one of the problem. We don't hope that this kind of problem we found in our daily practice. So back to these patients, of course, if we already define the patient suffering from WHO class 1, we can do ovulation induction by doing SMG, by giving SMG or combinations, FSH plus LH. And then, of course, it is also depend on ovarian reserves. In some patients with WHO class 1, also they don't have a good adequate ovarian reserve in some patients. However, most likely they have a good ovarian reserve. So any limitation for doing ovulation induction, if we do with gonadotropin, of course, it's not like the evidence. The ovulation induction with gonadotropin so far is still safe. And then for the patient with WHO class 1, even they can conceive naturally or spontaneously if the sperm is good and the tube also good. And not mandatory to go to IVF or even IUI. I think this is the important message to handle this patient. Thank you.
Thank you.
Salma, unmute yourself.
Thank you, sir. Thank you very much. Now we go for special guest remarks. Now I would like to take the remarks from special guest. I'm requesting the Professor Gulshanara Begum Madam to give her valuable remarks. Professor Gulshanara Madam. She is the professor and former head Department of Obstetrics and Gynae, Enam Medical College, Secretary General OGSB, and Organizing Secretary BMS, Office Secretary PCOS. Madam, please give your valuable remarks.
Thank you, Dr. Drummasalma. Assalamu alaikum. Very good afternoon, good evening. Respected chairs of this very auspicious webinar, to observe the World Infertility Awareness Month, June 2030, I would like to extend my gratitude for the organizer, Fertility and Sterility Society of Bangladesh, on this enthusiastic occasion. I'm honored and pleased to be here. Our two speakers, Professor T. Seeley, President Aspire, and Professor Bodhi, immediate past President Aspire, given very splendid and excellent presentation. Professor T. Seeley on management of Hong Kong perspective very nicely presented about the primary care, secondary care, and tertiary care, which is very much important for all of our gynecologists working in the Bangladesh, about the protocol of primary care, secondary care, and tertiary care. But good emphasis given by T. Seeley on training and accreditation. OGSB in Bangladesh always trying to improve the skill, knowledge, and practice of our member of the society by giving training in different occasions. And our society, Fertility and Sterility Society of Bangladesh, also arranging this type of training, this type of webinar, seminar, symposium to improve our faculties. And also the comprehensive range of surgery before IVF is also emphasized by T. Seeley. We are also giving various types of endoscopic surgery training in OGSB. Very recently, we have organized a basic endoscopic surgery training and fertility sparing training at OGSB hospital. So we are doing that. But very important one is raised by Professor T. Seeley about the accreditation. Accreditation is very important. So in our country, all the specialists, IVF specialists is here. Professor Firoza Begum, Professor Rashida Begum, Professor Minal Kanti Sarkar, Professor Maruf Siddiqui. as a panelist and discussed the scenario in a very befitting manner and very excellent way, we can arrange for accreditation of the training and the Center for IVF. We can take a step for this in our country. And another speaker, Professor Bodhi, very nicely presented about the management of infertility patient with low AMAs in Indonesia. Low AMAs is, we gynecologists also fear about to say the patient about the low AMAs, because the response of low AMAs in Bangladesh is like also Indonesia, because when they heard about the low AMAs, they immediately got marriage for pregnancy, or they take another pregnancy to overcome this problem. But the protocol to manage the AMAs with high gonadotropin, growth hormone, and the use of LAEs, which can results pregnancy positive. This is very excellent and very good information for our specialists. And your flow chart for management of infertile patient with low AMAs for good responder and the poor responder is a very excellent. Our gynecologist and the specialist can follow this flow chart, and they can usually get improved outcome for infertility patient. So thank you very much, our two speakers and our panelists also, Professor Firoza Begum, Rashida Begum, Professor Minal Sarkar, Professor Maruf Siddiqui, for your very excellent presentation and excellent remarks and excellent way of presentation of way of management of a very critical case given by Dr. Umma Salma. Thank you very much for this nice webinar. But one question is there by Professor Sharmin Abbasi. AMAs, we are doing AMAs, but what is the protocol of AMAs in our country? Whether it should be included as a basic investigation. Yes, we can decide about this in our society. And also Society of Fertility and Sterility Society of Bangladesh. Then AMAs is a very important point to know and to assess the patient and to use the guideline in a befitting manner. Thank you very much in everyone, and so many participants in this webinar. Thank you, our respected OGSB members who have joined there, and all the participants and all of you. Thank you very much.
Thank you, madam. Thank you very much for your valuable words. Now I am requesting Dr. Thilina Palihadanasa, please give your remarks, and would you please comment in short, infertility management, Sri Lankan perspective.
Can I request, are you listening to me? Can I just give my comments and go off?
Yes, yes.
Yes, sir.
I mean, my battery is dying down. I have just maybe 2-3 minutes battery left. I've come out. So can I just give my comments first?
Dr. Muralidhar.
Muralidhar Bhipai.
Now this is time for the remarks from Professor Dr. Muralidhar Bhipai sir. Sir is the Dean of Sikkim Manipal Institute of Medical Sciences and founder and current chairman, Karnataka College of Obstetrics and Gynecology. Please, sir.
Yeah, thank you very much. First of all, I would like to thank Dr. Professor Rashida Madam for inviting me as a chief guest for this excellent webinar that has been conducted. So I have been very carefully listening to Professor Lee, Professor Budhi, and all the 4 panelists. It was really, really enlightening. I'm sure all the delegates who have attended this would be benefited. First of all, I agree with Professor Lee that 80% of the infertility patients do not require IVF. And he has beautifully mentioned about the primary, secondary, and tertiary levels. And in the case discussion that followed, we could clearly make out that the secondary level patients were nicely managed, but the tertiary patients were also managed by the doctors who were not supposed to manage and they were supposed to refer, especially with respect to, as Maruf correctly said, the patient with the big fibroid should have been referred earlier when she was younger, so that it would have been easier to tackle. And similarly, the accreditation, the certification, and continual learning is a must. In India, we have ICMR as the nodal or the central apex body, which will do the regulations. Then we have so many others like ISAR we have Indian Fertility Society. They do the accreditations and certification courses. We have a university-based 3-year course, MCH, in reproductive medicine. And then time to time, there are so many conferences, CMEs are held, and that's how the continuous training is happening. With regards to the low responders or the Poseidon 4 groups, Dr. Budi mentioned beautifully, especially the protocol of his center. The younger the patient and the good the ovarian reserve, the management is easier. But when they go to higher age and they are poorly responding, no matter how much you use, the response will be less. Thankfully, in India, the home donation is allowed. But of course, it has become a little more stringent now. So if after 1 or 2 attempts, if we don't get the good eggs, we advise the lady home donation and they fairly agree. Similarly, with other gamete donation also, it is allowed, but surrogacy has become very, very strict. So in fact, only it's on the altruism levels, the surrogacy is allowed. Adoption, I'm not sure how many patients would finally accept, because ultimately they would like to have child from their own gametes. I was a little bit surprised with Professor Budi's, in their country, they are even stimulating 48-year-old. In India, it has become now after 45, you cannot do. So these are some of the comments that I would like to give. And thanks once again for inviting me for this excellent webinar.
Thank you, sir. Thank you very much for your excellent remarks. Now I'm requesting Dr. Thilina Palihawadana. Sir, please give your remarks, and would you please comment in short on infertility management, Sri Lankan perspective. Sir is the senior lecturer, Department of Obs and Gynae, University of Kelaniya, and research interest in infertility, assisted reproduction, fertility regulation, etc. His specialty in infertility and assisted reproduction. Please, sir.
Yeah, good evening, everyone. First of all, I would like to thank the organizing committee for the invitation and the opportunity to participate. Those were 2 excellent lectures and very opens your eyes and and get you think as to what we we should be doing as a country, and because I think most of these problems that we are faced when we are dealing with infertility and providing services in the region, a lot of issues are common to us. So in Sri Lanka, of course, we provide services, but I think as many countries in the region, one of the main drawbacks is it is still not available in the state sector. So it's because the health service is free in Sri Lanka, but infertility or fertility, or especially when it comes to advanced reproductive techniques, that is not available as a free service. So people have to resort to their own money. And I think one of the key features that we should keep in mind when we are working in this region is even the cost of an IVF cycle, though it is much less compared to a Western country, when you compare the cost per their earnings for a month, it becomes enormous. Even in a place like UK, the cost per IVF cycle compared to their average monthly earning is much less than when you compare it to in Sri Lanka. So one of the key limiting factors is the affordability. So their services are available in Sri Lanka. There are well-established centers. Service is there, but a lot of people find it much difficult to afford it. So I think that was one of the key priority areas. And I think as it was highlighted in these discussions, sometimes we may not be able to provide the best type of care, though the evidence is there, though we know, like, what is the best that we can do, for example, dual stimulation. So sometimes it becomes impossible for us to provide that level of care simply because it becomes unaffordable. The second main difference that I noticed, like, from this discussion was from what Professor Lee said, the accreditation and regulation. So again, in Sri Lanka, though the IVF or the ART services have been there for some time, still we do not have a very well-established official regulation body, and also the accreditation of centers is not well established. I think that is the work is underway. So I think that is something, like, that we should be we are focusing on at the moment. The cost per treatment is again, like, as I said, is a major drawback in providing services. And I think the other important thing from Professor Lee's talk is that the fact that we should be having different levels of care, and the primary, secondary, and tertiary. But one of the key important things is the knowledge that we have at the tertiary level should be given to the primary level. Because I think, as some of these case discussions that we discussed, as they highlighted, sometimes when the patients come to the tertiary level, a lot of time has passed, and that golden opportunity has passed. So it's very important, like, whether we are talking about advanced laparoscopic surgery or spending time doing treatment which may not be worthwhile, passing time and, like, advancing in age. So it's very important that we disseminate that knowledge that we have as specialists to the more primary levels, so that they would know when to refer patients without delay. So it's I think it's very encouraging to see like more than 100 people participating on a Sunday evening. I have to be honest, like, in Sri Lanka, that would be extremely difficult to achieve. So I really enjoyed the talk, and I think this is a very good exercise. And I think I'm learning a lot, like, as to what we should be doing in our country also. Thank you very much for the opportunity and the very valuable discussion.
Dr. Salma, I have got one question to Dr. Tilina. Can I ask one question?
Yes, sir. Yes, madam, please.
I'm just asking you, is there any health insurance policy in Sri Lanka for these IVF patients?
No, madam. The thing is, we do not have a national insurance policy simply because the free health services are free, like, in the state sector for all population. And the private insurance schemes, I'm sure it's the same worldwide. Most of the the private health insurance policies, they do not cover fertility care. So it's not covered.
I think we should adopt a policy in this region that these patients should be covered by health insurance so that they can try. Because in Bangladesh, after one cycle of IVF, the patient cannot come for the second cycle because they come at the age of, you have seen the patient's age, come after 38, 39, and they have nothing. It is very difficult for them to afford even a single IVF cycle. Without insurance, how they can have repeated cycle? I see their OGSB Secretary General is here. OGSB is doing much more work for the obstetricians and for the people of this country. I think Professor Gulshanara will take some initiative to start. We can convince the government to start an health insurance policy for our patients.
I think doing one thing. I think doing DMCH, taking they are doing a bit lower cost. They are taking, and also in CMH also. They are taking only a few for medicines only and giving the service. In public hospitals in our Bangladesh, there is a little bit IVF can be done at a lower cost.
Thank you. Thank you, Dr. Yes, madam. Thank you. Thank you, Dr. Thilina sir and Firoza madam and Moriam Farooqi Sati madam. We have many more questions in chat box, but due to shortage of time, we cannot take all that question. Now, with these remarks, we will go just conclude today's session. I'm feeling very much honored and privileged to be part of this webinar. My special thanks to the Nobista Pharma Limited, who are giving us the scientific support, and very special thanks to Professor Rohana sir, Professor Muralidhar sir, Dr. Thilina sir, and Professor T.C. Lee and Budi Wiyoko sir. Hope in future we can arrange many good webinars and also in person in Bangladesh. Very special thanks to Professor T.A. Chaudhuri sir, Professor Gulshanara madam, and all eminent panelists of today's webinar and all participants. With your leadership, FSSB will give better services to our infertile couple, hopefully. Thank you very much. Goodbye and stay well.
Thank you, Salma.